Welcome back to Not So Complicated, and today we are tapping into our series of USMLE First Study Step 1, and we are doing line by line pathology. Right now we have completed general principles, cardiovascular pathology and respiratory pathology, and today we are going into the realm of hematology and oncology, and we will be completing this series in 2 episodes, this topic in 2 episodes, because this is a very large topic. So let's begin from RVC morphology. So usually the physiological RVC morphology is that it has biconcave shape and its integrity is maintained from a protein called spectrin protein, right? You have to remember that, and it is a physiological state, and we will tap into this in detail in our physiology series, but we are going into pathology right now. So let's go to the pathological RVC morphology. So first one is acanthocytes or spore cells, right? Here it is figure. Acanthocytes are spore cells right here. And the associated pathology of acanthocytes is that liver disease, A beta lipoproteinemia, vitamin E deficiency. So the notes are projection of varying size at irregular intervals. That is, acanthocytes are asymmetric. A for acanthocytes and A for asymmetric. That is how we remember. And there is spores right here. These are spikes like the spikes of coronavirus, as you can remember. That is the way we can remember. So it is acanthocytes and also asymmetrical. And the second one is echinocytes or Bohr cells. So here it is, echinocytes. There is a blunted rays, there is a sharp rays of spikes in here, and there is a blunted rays, right? So that is Bohr cells. The associated pathology is liver disease, end-stage renal disease, and also pyruvate kinase deficiency, and they are smaller and more uniform projections than acanthocytes. So echinocytes are even. E for echinocytes, E for even. Also, you can get confused into spore cells and Bohr cells. Acanthocytes are spore cells, echinocytes are Bohr cells. Remember that. And also, E for echinocytes, E for even. The third one is dacrocytes. Dacro is also called tear. Dacro is tear. The meaning, literal meaning of dacro, the word dacro is tear. So basically, RVC sheds a tear because it is mechanically squeezed out of its home in the bone marrow. So RVC is mechanically squeezed out of bone marrow, so it sheds a tear. That is how you remember, like just like a teardrop, right? So sad. Just like teardrop. So, and it usually occurs in a case of myelofibrosis, is in a bone marrow infiltration, and in the sister sites where there is helmet cells. The sister sites are also called helmet cells, and it is fragmented RVCs like this, fragmented RVCs, and then they occur in microangiopathic hemolytic anemia, example disseminated intravascular coagulopathy, and also hemolytic uremic syndrome or thrombocytopenic that is thrombocytopenia. That is the case of thrombocytopenia. And then also HELP syndrome. HELP syndrome usually occurs in pregnant women. So that is it. And then mechanical hemolysis, heart valve prosthesis, is in heart valve prosthesis. And another type of cells is digmacytes, and also called bite cells. So you can remember like this: due to removal of hinge bodies by splenic macrophages, that is how digma cells are formed. These are also called bite cells because it looks like a mouth in here, right? These are also called bite cells. And then they dig them out or bite them off of the RVCs. That is how we remember. So it occurs in G6PD deficiency. And another type is elliptocytes, and elliptocytes usually occurs in hereditary elliptocytosis. It is caused by the mutation in genes including RVC membrane protein, that is spectrin protein that I have talked about earlier, spectrin protein, right? So that is how elliptocytes occurs. Here it is figure of elliptocytes. And also there are spherocytes. Spherocytosis spherocytes in hereditary spherocytosis, and also in autoimmune hemolytic anemia. They are small spherical cells without central pallor, decreased surface area to volume ratio. There you can see there is no central pallor like this. There is no central pallor, right? And then also there are macrovalocytes. These are seen in megaloblastic anemia, also hypersegmented polymorphonuclear nucleocytes. These are macrovalocytes, right? These are quite a large cells than the size of normal RBC, and there are target cells. You have to remember this one very specifically because target cells is seen in SBC disease and also in thalassemia, main in thalassemia. So you can remember like HALT, HALT, HALT. H for HBC disease, A for osteopenia, and then L for liver disease, T for thalassemia. HALT set the hunter to his target, that is increased surface area to volume ratio. In spherocytes, there is decreased surface area to volume ratio, but in target cells, there is increased surface area to volume ratio. And in sickle disease, you can see that figure of target cells right here, right? Target cells because it looks like a target of archery, right? And then sickle cells, we all know about sickle cells. It occurs in sickle cell anemia. Sickling occurs with low oxygen conditions, example high altitude or acidosis. High HbS concentration, that is in dehydration, can also occur sickling. So sickle cell disease is a hereditary disease. That is how sickling occurs. So that is RBC morphology, pathological RBC morphologies. And then there are RBC inclusions, right? So RBC inclusions are that there are types of RBC inclusions. Inclusions are those bodies who, except for RBCs and other cells. So they have different types, and they are seen differently in different smear, like in bone marrow smear and peripheral smear. So that is how we go. And then in bone marrow there are iron granules in sideroblastic anemias. Sideroblastic anemia actually occurs, the most common cause of sideroblastic anemia is lead poisoning, and also myelodysplastic syndromes and chronic alcohol overuse. There are perinuclear mitochondria with excess iron forming ring in ring sideroblasts. They require Prussian blue stain to visualize. Here you can see sideroblasts, right? They require Prussian blue stain. Which stain? Prussian blue stain. And there is also perinuclear thing. There is perinuclear thing in mitochondria, right? Perinuclear mitochondria with excess iron. And in peripheral smear, there is Howell's olivaries, and it is usually seen in sickle cell disease and also functional hyposplenia or asplenia cases. The notes is that it is basophilic nuclear remnants do not contain iron, and also they are usually removed by splenic macrophages, so they do not contain iron. So there's basophilic nuclear remnants. You have to remember that, like this, Howell's olivaries. And the other one is basophilic stippling. It occurs in sideroblastic anemias and also in thalassemia. That is basophilic stippling. Basophilic ribosomal precipitates occurs. They do not contain iron. So that is how basophilic stippling is. And the other body is Pappenheimer bodies, and they are also occurring in sideroblastic anemias. The notes is that the basophilic granules contain iron in this case. In basophilic stippling, there is no iron, but in Pappenheimer bodies, there is iron. Right? And then they are also called Pappenheimer bodies. You can remember like that. Pappenheimer bodies, because they have iron. The hammer is usually made up of iron, right? So here is Hinz bodies. Here you can see these are inclusion bodies, the Hinz bodies, and it usually occurs in G6PD deficiency. The denatured and precipitated hemoglobin contain iron. Phagocytic removal of Hinz bodies is by bite cells. Take a bite of Hinz, that is ketchup. But a bite of Hinz, as we talked about it in the bite cells, that is stigmacytes. Stigmacytes usually occurs due to removal of Hinz bodies by splenic macrophages, as we talked about it earlier in notes. So that is how Hinz bodies occurs, like a bite of Hinz, right? So that is how the inclusions are finished. Now tap into the anemia. What is anemia actually? Anemia is the low hemoglobin content in our body. In a broad definition, we can say that the normal range of hemoglobin in our body is 14 to 16 gram per deciliter for male and 12 to 16 gram deciliter for female, right? So let's go. The anemias. Anemias can be classified in three different types in the basis of their shape. That is microcytic, normocytic, and also microcytic, normocytic, and also macrocytic. So in the microcytic cases, what actually occurs is that the normal cells, for example, this is diameter of RBC, then in microcytic the diameter decreases, and in macrocytic the diameter increases. That is how it occurs. How we measure this diameter is that the central pallor to the rim, the diameter of the central pallor to the rim is measured, and also this is decreased in the case of microcytic anemia and increased in the cases of macrocytic anemia, and the unit of measurement is femtoliter. So MCV is, that is mean corpuscular volume, is less than 80 femtoliter in microcytic anemia, normocytic 80 to 100 femtomilliliter, and in macrocytic there is greater than 100 femtoliter. So that is how we see. And the size of the RBC is usually compared to the mononuclear lymphocytes, right? That is compared to the mononuclear lymphocytes. And in microcytic anemia, the hemoglobin is affected. That is in tail cases. Tail cases is T for thalassemias, A for anemia of chronic disease, I for iron deficiency, that is late, and L for lead poisoning. In defective globin chain occurs or hemoglobin is affected in microcytic anemia, that is tail cases, T for thalassemias, A for anemia of chronic disease, and then I for iron deficiency, that is late, and L for lead poisoning. And in normocytic anemias, there are two types of anemias, that is non-hemolytic anemia and hemolytic anemia. In non-hemolytic anemia, RBC lysis doesn't occur, but in hemolytic, there is RBC lysis. So, as the RBC gets lysed, then the hemoglobin is released from the RBC, and that causes anemia. So basically, in non-hemolytic anemia, there is low reticulocyte index, but in hemolytic, there is high reticulocyte index. And also, in non-hemolytic anemia, the causes are iron deficiency, that is early. In late iron deficiency, that occurs microcytic anemia, and anemia, chronic disease, and also aplastic anemia, chronic kidney disease, acute blood loss hemorrhage, that occurs non-hemolytic anemia. And in hemolytic anemia, there is also further classification of intrinsic and extrinsic anemias. Like the hemolysis occurs in the intrinsic due to intrinsic causes, like this is RBC, right? There are intrinsic causes that causes hemolysis, that is intrinsic hemolytic normocytic anemia, and this is RBC, but there are external factors that is causing the lysis of this cell, so that is extrinsic factors, right? External factors like autoimmune, some antibodies are attacking this RBCs or like that, and microangiopathic, macroangiopathic, and also infections as in malaria. In malarial cases, the antigens or the pathogen attacks the RBCs, and they are lysed or destructed, right? So that causes hemolytic anemia. In intrinsic causes, there are three different types: the membrane defects, and also enzyme deficiencies, and hemoglobinopathies. In membrane defects, the main is hereditary spherocytosis that we talked about earlier, and also paroxysmal nocturnal hemoglobinuria is there. And in enzyme deficiencies, that is G6PD deficiency. G6PD deficiency had a special type of cell, right? That is bite cells or digmacytes that we talked about earlier in also Heinz bodies, right? So let's go. And also there is pyruvate kinase deficiency, and in hemoglobinopathies there is sickle cell anemia and HBC disease. That is how we conclude our normocytic anemia. The macrocytic anemias, the size is larger, that is larger than 100 femtoliter, and it is divided into megaloblastic or non-megaloblastic. In megaloblastic, there is obviously the increase in size of cell, and it is due to DNA is affected. How actually DNA affects? The DNA actually matures from the folate, that is vitamin So it matures from the folate, right? So folate deficiency causes defective DNA synthesis, also vitamin B2 well deficiency, orotic aciduria, and in defective DNA repair. There is defective DNA synthesis and also defective DNA repair that it causes Fanconi's anemia. So what is Fanconi's anemia? It is the most broad pathology for macrocytic anemia, in megalocytic anemia, and also Fanconi anemia is that defective DNA repair. And there is diamond black fan anemia and liver disease, chronic alcoholic overuse that causes non-megaloblastic macrocytic anemia. So we will talk about all of these anemias in a very concise manner in later. So diamond black fan anemia, we'll talk about this also. That is how we conclude the classification of anemias, right? So let's go to the reticulocyte production index. So what is reticulocyte actually? Reticulocyte is immature RBC, and that indicates that there are a lot of RBC synthesis occurring in our body. That indicates that is indicated by the reticulocyte. And reticulocyte has a different diagnostic function. We can look at that right here. So it is also called corrected reticulocyte count. That is, production index is also called corrected reticulocyte count. It is used to correct falsely elevated reticulocyte count in anemia. So since there is a decrease in RBC, then what is doing that reticulocyte count is increasing? That is because there is occurring of lysis of RBCs or decreased RBCs, right? So decreased RBC leads to the release of erythropoietin, that is EPO, that will lead to increased release of erythropoietin from the kidneys, right? And that will do reflex RBC synthesis, that is causing polycythemia. And during the RBC synthesis, the reticulocyte count increases because it is immature form, and RBC cannot get matured in anemia. That is why reticulocyte count is increasing. And it measures appropriate bone marrow response to anemic conditions, that is effective erythropoiesis, as I talked about it earlier. And high RPI, that is greater than 3, indicates compensatory RBC production, but low RPI indicates inadequate response to correct anemia. So that is what it is. How do you calculate RPI? That is percentage reticulocytes into actual hematocrit by normal hematocrit by maturation time. That is how we calculate reticulocyte production index. There is another index, Menzor index. This is very much important in a case of thalassemia. Sorry. So it is used to differentiate between thalassemia trait and iron deficiency anemia. IDA and thalassemia trait is differentiated by a Menzor index, and an index of less than 13 suggests thalassemia. What is the index actually? It is MCV by RBC count. MCV is mean corpuscular volume. So Menzor index is MCV by RBC count. So less than 13 means thalassemia. There is a way to remember this, that there is less in thalassemia, that is thalassemia. So there is less than 13 index, Menzor index, in a case of thalassemia, and greater than 13 suggests iron deficiency anemia. So let's do the interpretation of iron studies, right? So serum iron obviously decreases in iron deficiency anemia and also in chronic disease and in hemochromatosis. In hemochromatosis, there is increase in serum iron because there is increased concentration of hemoglobin, as we say. And in pregnancy or OCP use, that is non-reliable. And the transferrin or TIBC, total iron binding capacity, increases in iron deficiency anemia, and it decreases in a chronic disease, and also it decreases in hemochromatosis, and it increases in pregnancy or OCP use. So we have to remember this, right? So in pregnancy or OCP use cases, so if we calculate our transferrin, it gets increased. That is, total iron binding capacity is increased, so it may create false results. So we have to consider this. And in ferritin, it is decreased. Ferritin is actually a protein that stores iron if there is no use of more iron in our body. And in chronic disease, it increases, and hemochromatosis, it increases, it is non-reliable in pregnancy. And percentage transfer in saturation serum iron by TIVC, it decreases most in iron deficiency. Then it may not change or decrease in chronic disease, and it increases most in hemochromatosis, and also it decreases in pregnancy or OCP use. So let's see primary disturbance. So transferrin, the function of transferrin is that it transports iron in blood. We will talk about iron transport and hemoglobin synthesis detailed in our biochemistry session. So if you don't want to miss it, then subscribe. Yes, I'm just kidding. We will do that at any ways. I just need you to subscribe so that this gets sustained, this series gets sustained, I don't get fed out of it. So that is it. So TIVC is total iron binding capacity, as I talked about it earlier, indirectly measures transferrin, and ferritin is primary iron storage protein in our body, protein of our body. So as I talked about it earlier, ferritin. And evolutionary reasoning, pathogens use circulating iron to thrive. So the body has adapted a system in which iron is stored within the cells. Like this is intestinal lumen, iron is stored in here. Like apoferritin is bound to the iron, and it becomes ferritin and gets stored like that. Those details is a very much details. We'll talk about that in our biochemistry series, as we talked earlier. So let's go into the microcytic hypochromic anemia, each of it. So hypochromic is, we measure pallor. How do we measure pallor? So every RBC has a central pallor, right? So vernier caliper is used to measure this pallor. If pallor increases, that is hypochromic anemia. If pallor decreases, that is hyperchromic anemia. But hyperchromic anemia is very rare. And in microcytic hypochromic anemias, MCV is less than 80 femtoliters. So for examples, there are iron deficiency here, and that is decreased iron deficiency due to chronic bleeding occurs. Like example, GI loss. GI loss can occur due to internal hemorrhage or esophageal varices or acute pancreatitis kind of thing, or also Mallory Weiss tear and Burap syndrome, it can occur. And malnutrition, absorption disorders, GI surgery as in gastrectomy, or increased demand as in pregnancy, that will lead to decrease in final step in hem synthesis. So how does labs show in iron deficiency anemia? There is decreased iron, there is increased iron binding capacity, obviously, decreased ferritin because the storage of iron is already finished, and increased free erythrocyte porphyrin because there is reflex increase of erythropoiesis right here, as we talked about earlier. And there is increased RDW and decreased RI, and also microcytosis and hypochromasia. Microcytosis is that the decrease in cell size, and hypochromasia is that the decrease in cell color. Like that is increased central pallor, as I talked about it earlier, right here, right? So how do the symptoms feel? The symptoms are usually fatigue, obviously, because there is less iron. Less iron means less oxygen transport. Less oxygen transport means there is fatigue. And also this RDW here, which is the red blood cell distribution width, it measures how varied your red blood cells are in size and volume. That is the function of it, right? So symptoms, there can also occur restless leg syndrome, pica, that is persistent craving and compulsive eating of non-food substances. Like if a child has a frequency of increasing eating of soil while playing, that is pica, right? That is as he is craving iron in soil, and that indicates that he is in desperate need of iron. So also spoon nails, that is koilonychia, is also the case of iron deficiency anemia. It may manifest as glossitis, that is inflammation of tongue, and cirrhosis, and Plummer-Pinson syndrome, that is triad of iron deficiency anemia, esophageal waves, and dysphagia. We have to remember this is very high yield, And this is a type of question that is asked if the examiner wants to confuse you. Plummer Benson syndrome, it occurs as a triad of IDA, esophageal waves, and dysphagia, right? So we have a figure here where it is. This A figure and this B figure, they should be here, right? So maybe these are the things. A right here and then B right here. Here you can see the pallor, right? There is decrease in cell size and also increased pallor. Here you can see the diameter of pallor is increased, and it is actually compared with our lymphocytes. So alpha thalassemia, there is actually thalassemia is a globins and deformity. So alpha globins in deletions on chromosome 16 does thalassemia, that is alpha thalassemia, that will lead to decrease in alpha globin synthesis, and it may have cis deletion, that deletions occur on same chromosome, or transdeletion, that deletions occur on separate chromosomes. Normal is alpha 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 alpha. So it actually the symptoms manifest as per the gene deletion, right? How many genes are mutated or deleted, it depends on that. So often increased RBC count is there, in contrast to IDA, that is increased prevalence in people of Asian and African descent. The target cells are on peripheral smear. In thalassemia, there are target cells, we talked about it earlier, right? In our first slide, these are the target cells right here. Target cells. So let's see, alpha 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 alpha, there is type 1 alpha globin genes deleted. There are 4 alpha globin genes, right? But if there is only one gene deleted from one chromosome, there are 2 chromosomes, a pair of 16 chromosomes. So if there is only one gene deleted, it is called alpha thalassemia minima, and there is no anemia, so that is silent carrier, right? And if there are 2 genes from the same chromosome, or that is cis mutation, or 2 genes from different chromosomes, that is transmutation, that can occur. So that is alpha thalassemia minor. So there is minima, there is minor, and it is manifested as mild microcytic hypochromic anemia. And there is 3 genes affected, alpha, 2 alpha genes from one chromosome and 1 alpha gene from one chromosome. It is also called hemoglobin H disease, that is HbH disease, and it is due to excess beta globin forms beta 4, right? There is moderate to severe microcytic hypochromic anemia in this case, and also there is a possibility that all 4 genes are impacted. So all 4 genes are deleted, that is called hemoglobin Bart's disease. There is no alpha hemoglobin, excess gamma globin forms gamma 4. So hemoglobin Bart's disease, we have to remember this is very high yield. All 4 genes of 16 chromosome is deleted, that leads to hemoglobin Bart's disease, and it is a case of alpha thalassemia. There is a symptom of hydrops fetalis, that is incompatible with light. Hydrops fetalis, that is usually the manifestation of a fetus, right? So that is how we complete our alpha thalassemia. So let's go to the beta thalassemia, which is the continuation of our microcytic hypochromic anemia. So beta thalassemia, there is point mutation in splice sites or Kozak consensus sequence, that is promoter on chromosome 11. You have to remember the differences, don't get confused. Alpha thalassemia, there is chromosome 16 and there is gene deletions, and there is point mutations. The two different mutations are there. There is deletion in alpha thalassemia, and there is point mutation in splice sites or Kozak consensus sequence, that is promoter sequence of chromosome 11. Chromosome 16 in alpha thalassemia, chromosome 11 in beta thalassemia. So decrease in beta globin synthesis occurs, or absent beta globin synthesis occurs. It is highest prevalence in Mediterranean populations. So let's see, there is similar kind of manifestations in here. If only one gene is point mutated, then that is called beta thalassemia minor, and the clinical outcome is mild microcytic anemia and also increased SPA2. And the second type is that beta plus or beta plus beta 0, that is beta thalassemia intermedia. It has variable anemia ranging from mild to asymptomatic to severe to transfusion dependent, right? And type 2 is that beta 0, both genes are point mutated, and it is also called beta thalassemia major or Cooley anemia. So manifestation is very important for our step 1. This is very high yield, you have to remember. It causes severe microcytic anemia with target cells. Now you have to be able to visualize how target cells look like. And also poikilocytes, anisopoikilocytes, right? Anisopoikilocytes requiring blood transfusions. What is anisopoikilocytosis? It is actually distorted cell, increase in synthesis of distorted cells, and there is blood transfusion requirement. Primary risk of secondary hemochromatosis is there in blood transfusion, and it also causes marrow expansion. There is crew cut appearance in skull X-ray. You have to remember this. You can see here, this is a crew cut X-ray finding. And also there is skeletal deformities, extramedullary hematopoiesis, that leads to SSM. Here you can see. And then it leads to increased risk of parvovirus B19 induced aplastic crisis, and that leads to increased hemoglobin, fetal hemoglobin or SBA2, hemoglobin A2, and it becomes symptomatic after 6 months when fetal hemoglobin declines, because fetal hemoglobin is protective in nature. And chronic hemolysis leads to pigmented gallstones. Chronic hemolysis also occurs in response to blood transfusion. So there is another type that is called sickle cell beta thalassemia. The type is beta plus HBS and beta not HBS. So it leads to mild to moderate sickle cell disease depending on whether there is decreased beta plus HBS or absent beta not HBS, beta globin synthesis. So let's go to the lead poisoning case, right? In lead poisoning, what is the toxic effect of lead in RBCs? Actually, lead inhibits ferrosilitase and ALA dehydratase enzymes, right? So ferrosilitase and ALA dehydratase enzymes are those enzymes required in the synthesis of hemoglobin. So that inhibits ferrosilitase, that is the last step, the last enzyme required for hemoglobin synthesis, and also ALA dehydratase. So that leads to decreased heme synthesis, and then increased RBC protoporphyrin, that is the intermediate product of RBC for hemoglobin formation, protoporphyrin. And it also inhibits rRNA degradation that leads to RBCs retain aggregates of rRNA, that is basophilic stippling, as we talked about it earlier. We saw the visualization also, right? There is no accumulation of iron in basophilic stippling. And the symptoms is lead. The symptoms of lead poisoning is lead. So double L, double E, double A, single D. So lead lines on gingivae, that is bottom lines, are seen, and on metaphysis of long bones, and also on X-ray. There you can see lead lines. So symptoms of lead poisoning in hemoglobin is that lead. So lead lines, double L for lead lines, which are also called Barton lines, are seen on gingivae, and also double E is encephalopathy and erythrocyte basophilic stippling. Encephalopathy and erythrocyte basophilic stippling. Double A is abdominal colic and sideroblastic anemia, and then D is drops, wrist drop and foot drop. That is also double D. You can remember like double D, wrist drop and foot drop. So double L, double E, double A, double D, that is lead poisoning. So L for lead lines on gingivae or bottom lines, E for encephalopathy, E for erythrocyte basophilic stippling, A for abdominal colic, and then A for sideroblastic anemia. D for wrist drop, and also D for foot drop. The treatment distillation with Soximer, EDTA, and also dimercaprol, right? And increased exposure risk is in children, chipped paint in old houses built before 1978, and in adults in workplace, example batteries, ammunition, there is exposure to lead. Let's go to the sideroblastic anemia right here. So what is sideroblastic anemia actually? Sideroblastic anemia, the causes are genetic, that is X-linked defect in ALA synthase gene, and also it can be acquired myelodysplastic syndromes and reversible. Alcohol is the most common, also lead poisoning, vitamin B6 deficiency, copper deficiency, and drugs like isoniazid and linezolid can cause sideroblastic anemia. In the lab findings, we see increased iron content, normal or decreased TIVC, increased ferritin because increased iron content leads to increase in storage of iron, and also ring sideroblasts are seen with iron-laden Prussian blue stained mitochondria seen in bone marrow. In bone marrow aspirate, what are seen? The seen things are ringed sideroblasts with iron-laden and also Prussian blue stained mitochondria. Peripheral body smear shows basophilic stippling of RBCs. Some acquired variants may be normocytic or macrocytic. The treatment is pyridoxine, that is vitamin B6, a cofactor for ALA synthase. So why pyridoxine? Because vitamin B6 is a cofactor for ALA synthase. You have to note it down right now. Note it down if you even are studying and if you even are with me right now. So let's go to the macrocytic anemias. We have completed our microcytic hyperchronic anemias. Let's go to the macrocytic anemias, right? So as we talked about earlier, in macrocytic anemias, there is large increase in size, that is mean corpuscular volume is greater than 100 femtoliters. There are different types of macrocytic anemias. We talked about it, megaloblastic anemia and also non-megaloblastic anemia. In megaloblastic anemia, there are subtypes like folate deficiency and vitamin B12 or covalent deficiency and orotic aciduria. Let's see megaloblastic anemia right here. What actually happens, and there is impaired DNA synthesis that leads to the maturation of nucleus of precursor cells in the bone marrow, delayed relative to maturation of cytoplasm. That is what it occurs. So maturation of nucleus of precursor cells in bone marrow is delayed relative to maturation of cytoplasm. That leads to impaired DNA synthesis, right? That is why impaired DNA synthesis, and it occurs due to vitamin B12 deficiency, folate deficiency. Folate deficiency is very much required for DNA maturation, and also vitamin B12 is required. Medications can cause like that: phenytoin, methotrexate, sulfadrox or hydroxyurea. The findings are RBC macrocytosis, hypersegmented neutrophils, and also glossitis. Here you can see. This is the finding of megaloblastic anemia. That may occur due to folate deficiency. It causes of folate deficiency is malnutrition. Example, chronic alcoholic overuse. Malabsorption can occur, and also drugs like methotrexate, trimethoprim, or phenytoin can cause folate deficiency. Like viable folate deficiency occurs actually. Dihydrofolate occurs because methotrexate, drugs like methotrexate, what they do is that they inhibit the enzyme that converts folate into dihydrofolate, right? So that is why viable folate is decreased, and it is increased requirement also. And hemolytic anemia and pregnancy, there is folate deficiency. The findings are that there is increase in homocysteine levels and normal methylmalonic acid, and no neurologic symptoms versus B12 deficiency. So difference between vitamin B12 symptoms and folate deficiency, which is vitamin B9 symptoms, is that there is no neurologic symptoms in vitamin B9, but there are neurologic symptoms in vitamin B12 deficiency. The causes of the B12 deficiency can be pernicious anemia, then malabsorption as in Crohn's disease, pancreatic insufficiency, gastrectomy, insufficient intake, example veganism. So In vegans, there is vitamin B12 deficiency. You have to remember that for epidemiology. And also Diphyllobothrium latum, that is fish tapeworm, can cause vitamin B12 deficiency. The findings is increased homocysteine, increased methyl malonic acid. Why these two specific biochemical parameters are increasing? Because of what is actually the normal metabolism of folate and cobalamin that is disturbed, right? So these are the intermediate products right here. So neurologic symptoms of vitamin B12 deficiency include reversible dementia. Dementia is memory loss, and also subacute combined degeneration due to involvement of B12 in fatty acid pathways and myelin synthesis. Myelin synthesis is impaired. Spinocerebellar tract, lateral corticospinal tract, dorsal column dysfunction occurs. Folate supplementation is given in vitamin B12 deficiency that can correct anemia, but it worsens neurological symptoms. You have to remember this. So, in vitamin B12 deficiency, folate supplements can be given that will correct the anemia, but it will worsen neurologic symptoms. Very high yield, remember this. And it is histologically diagnosed with the Schilling test, a test that determines if the cause is dietary insufficiency or malabsorption. And also anemia secondary to insufficient intake may take several years to develop due to liver's ability to store B12 versus folate deficiency, which takes weeks to months. So basically, another difference between folate deficiency and cobalamin deficiency is that the cobalamin deficiency will take years to develop the clinical symptoms or anemia versus folate deficiency. So another underlying cause is uric aciduria. Uric aciduria is inability to convert uric acid to UMP, that is de novo synthesis of pyrimidine. So that is due to the big defect in UMP synthase enzyme, and it is very autosomal recessive. It is present in children as failure to thrive, developmental delay, and also megaloblastic anemia refractory to folate and B12. No hyperammonemia or ornithine transcarbamylase deficiency occurs, and that will lead to increase in uric acid with hyperammonemia. So uric acid is found in urine. In the findings, the treatment is uridine monophosphate or uridine triacetate to bypass mutated enzyme. So another type here is non-megaloblastic anemia. It is a type of macrocytic anemia, as we talked earlier. So macrocytic anemia, in which DNA synthesis is normal, is non-megaloblastic anemia. The very classic example of this is Diamond-Blackfan anemia. So RBC macrocytosis without hypersegmented neutrophils is present in non-megaloblastic anemia. This is high yield because this is high yield for a reason that it can ask in step 1. So Diamond-Blackfan anemia is a congenital form of pure red cell aplasia versus Fanconi anemia, which causes pancytopenia. So in Diamond-Blackfan anemia, there is a congenital form of pure red cell, only red cell aplasia occurs, but in Fanconi anemia, there is pancytopenia. There are red cells, white cells, and platelets. All of them are decreased in Fanconi anemia. So rapid onset anemia within first year of life due to intrinsic defect in erythroid progenitor cells. This is the cause right here. That is intrinsic defect in erythroid progenitor cell. This is the cause of Diamond-Blackfan anemia. So findings are increase in percentage fetal hemoglobin, decrease in total hemoglobin. There is short stature, craniofacial abnormalities, and also upper extremity malformations that will lead to triphalangeal thumbs in up to 50% of cases, right? So a pure diamond causes pure red cell aplasia. That is how we remember. We don't have to remember like this. This is very simple. Diamond-Blackfan anemia will cause pure red cell aplasia. You have to remember that in the tip of the tongue. You don't have to make mnemonics for that. So another here is normocytic normochronic anemia, and then we will talk about non-hemolytic normocytic anemias, then intrinsic hemolytic anemias. That is how we will finish for today. Until this extrinsic hemolytic anemia, so we will try to cover it up, but let's see how long it goes. So in normocytic normochromic anemias, the size of the red cells is normal, and also the pallor is normal. That is how normocytic normochromic anemia occurs. Just the number of hemoglobin is decreased. Normocytic normochromic anemias are classified as non-hemolytic or hemolytic. So the hemolytic anemias are further classified according to the cause of the hemolysis, intrinsic versus extrinsic. We have talked about all of these earlier, right? In a classification in detail. Here you can see red blood cell, splenic macrophage will lead to unconjugated bilirubin synthesis that will get conjugated in liver, and that will be converted into urobilinogen and then stercobilinogen. That is a normal pathway. So intravascular hemolysis, this is the extravascular hemolysis case, right? And in intravascular hemolysis, there is intrinsic cause, and it will lead to hemoglobin. Right here, there is RBC burst that is causing hemoglobin release. So there are dimers formation in here. Dimers bind haptoglobin. That is why even in a case of anemia, the hemoglobin or RBCs cannot get out of the kidney. But if they are extremely splitted, then hemoglobinuria can occur. If haptoglobin capacity is exceeded, like haptoglobin is a limiting thing here. If the haptoglobin synthesis is normal, but there are increased synthesis of these splitted hemoglobins, then hemoglobinuria can occur. So there is two hemolysis, intravascular and extravascular hemolysis. Right here, non-hemolytic and hemolytic, but hemolytic also intravascular and extravascular hemolytic. We didn't talk about it earlier. We'll talk about it now. The findings in intravascular hemolysis that there is decrease in haptoglobin, as we talked about it, and increase in cystocytes and blood smear, and the characteristic hemoglobinuria, hemosideruria, and also urobilinogen is in urine. Notable causes are mechanical hemolysis, example prosthetic bulbs. This is very common. So if a case is presented with prosthetic bulbs, you have to consider a symptom, like you have to consider the case of anemia. That is a normocytic normochromic anemia. Paroxysmal nocturnal hemoglobinuria, also microangiopathic hemolytic anemias. In extravascular hemolysis, the mechanism is that macrophages in spleen clear RBCs. This is the mechanism. Macrophages in spleen clear RBCs. That is extravascular hemolysis. That is hypersplenism occurs. Right? The findings is splenomegaly, spherocytes in peripheral smear, most commonly due to hereditary spherocytosis and autoimmune hemolytic anemia. So spherocytes are seen in peripheral blood smear. There is no hemoglobinuria or no hemosideruria. That is the difference from intravascular hemolysis right here. And it can present with urobilinogen in urine. So let's talk about non-hemolytic normocytic anemias. So we talk about hemolytic and also intravascular and extravascular hemolysis. There are two major things right here: anemia of chronic disease and aplastic anemia. They cause non-hemolytic normocytic anemias. So basically, let's go from the anemia of chronic disease. As in inflammation, what happens is there is increase in interleukin 6, right? That will lead to increase in hepcidin. Hepcidin is released by livers and it binds ferroportin on intestinal mucosal cells and macrophages, thus inhibiting iron transport. That will lead to decrease in release of iron from macrophages and decrease in iron absorption from the gut. What actually happens? There is intestinal lumen cells, right? So there is a ferroportin right here, and there is also ferroportin right here. This is DMT1, that is divalent. That is a divalent protein in here. It also is acts as a channel for iron to go from this lumen to the intestinal cells. And these cells lead to the plasma from ferroportin. But if there is increase in hepcidin synthesis due to inflammation, that ferroportin is bound to the hepcidin. So it leads to the decrease in release of iron from the macrophages, right? That is how anemia of chronic disease occurs. It is associated with conditions as in chronic infections, neoplastic disorders, chronic kidney disease, and autoimmune diseases like SLE, rheumatoid arthritis. The findings are decrease in iron, decrease in TIVC, increase in ferritin. So normocytic, but can become microcytic. The treatment is addressing underlying cause of inflammation, judicious use of blood transfusion. We have to consider erythropoiesis stimulating agents such as APO, example in chronic kidney disease also. So aplastic anemia, let's see. There is a failure or destruction of hematopoietic stem cells. So the causes include reducing volume from inside diaphysis. Remember this. Reducing volume from inside diaphysis is occurring in aplastic anemia. R for radiation is the cause. B for viral agents as in Epstein-Barr virus, HIV virus, hepatitis viruses. And F for Fanconi anemia, which causes pancytopenia. Autosomal recessive DNA repair defect it is, and it leads to the bone marrow failure, right? And normocytosis and macrocytosis are seen in the CVC. Common associated findings include short stature, cafe, owlatus spots, and also thumb or radial defects, predisposition to malignancy. Common associated findings, here we have to remember this: short stature, cafe, owlite spots, and thumb or radial defects of predisposition to malignancy. And then I for idiopathic mephylacate hepatitis, and D for drugs, that is benzene, chloramphenicol, alkylating agents, or antimetabolites. So reducing volume from inside diaphysis, that is failure or destruction of hematopoietic stem cells. Since hematopoietic stem cells are formed inside diaphysis, we can say like that. Reducing volume of RBCs, obviously, the reducing volume from inside diaphysis is the cause of aplastic anemia. R for radiation, B for viral agents as in EBV, HIV, and hepatitis viruses. F for Fanconi anemia, I for idiopathic, and D for drugs. It's like benzene, chloramphenicol, alkylating agents, and antimetabolites. What are the findings? The findings of aplastic anemia is the decrease in reticulocyte count, increased in erythropoietin. Obviously, due to this is the reflex increase that will lead to secondary polycythemia in long term. Pancytopenia, characterized by anemia, leukopenia, and thrombocytopenia, versus aplastic crisis, which causes anemia only. In aplastic crisis, there is anemia only, obviously. Normal cell morphology is there, but hypocellular bone marrow with fatty infiltration is seen. Hypocellular bone marrow with fatty infiltration. You can see the fat globules in here. These all are fat globules, and this is a bone marrow aspirate. That is increase in adipose tissue in bone marrow in aplastic anemia. The symptoms include fatigue, malaise, pallor, purpura, mucosal bleeding, and petechiae, and also infection. The treatment is withdrawal of offending agent, immunosuppressive regimens, example anti-thymocyte globulin and cyclosporin, also bone marrow allograft, RBC or platelet transfusion, bone marrow stimulation as in GM-CSF. Let's talk about intrinsic hemolytic anemias and also extrinsic hemolytic anemias. So in intrinsic hemolytic anemias, there are types of different intrinsic hemolytic anemias. These are hereditary spherocytosis, paroxysmal nocturnal hemoglobinuria, and G6PD deficiency, pyruvate kinase deficiency, sickle cell anemia. We have to remember each of these diseases in detail, right? These are very high yield. Hematology and oncology is very much asked portion of pathology in step 1. Since pathology itself holds 42% of weightage of questions. So in hereditary spherocytosis, there is primarily autosomal dominant. It is a case of autosomal dominant. And due to defect in proteins interacting with RBC membrane, skeleton, and also plasma membrane like ankyrin, band 3 protein, protein 4.2, and spectrin. We have to remember all of this protein right here. Ankyrin protein, band 3 protein, and protein 4.0 and all 4.2, and also spectrin protein. So that is what the defective in this case, and that will lead to small round RBCs with no central pallor. there is no central pallor in spherocytes. So decrease in surface area or dehydration, that will lead to increase in mean corpuscular hemoglobin concentration, and also premature removal by spleen, that is extravascular hemolysis occurs. So findings, we have to remember the findings. There is increase in MCHC. Findings, let's go in detail. There is splenomegaly, pigmented gallstones, aplastic crisis, parvovirus, B19 infection causes aplastic crisis. Parvovirus, B19 infection causes aplastic crisis. Okay. Labs, decrease in mean fluorescence of RBCs in eosin 5 maliate, that is EMA binding test. There is decreased mean fluorescence of RBC, and there is increased fragility in osmotic fragility test. There is RBC hemolysis with exposure to hypertonic solution, because this is a cell. For example, this is a spherical cell. There is defective membrane protein, right? So there is very high intake of fluid in hypertonic solution that will lead to the enlargement of this cell, and the enlargement of this cell will then cause fragility, that is increased fragility is seen in osmotic fragility test. So it is normal to decreased MCV with abundance of RBCs is seen. The treatment is splenectomy. Normal to decreased MCV. So MCV is mean corpuscular volume is decreased because surface area to volume is also decreased, and also increase in mean corpuscular hemoglobin concentration, because since the size is decreased but hemoglobin concentration is the same, so mean corpuscular hemoglobin concentration increases. In paroxysmal nocturnal hemoglobinuria, what is it? It is actually hematopoietic stem cell mutation, hematopoietic stem cell mutation, and it will lead to increased complement mediated intravascular hemolysis, especially at night. That is why it is called nocturnal hemoglobinuria. The acquired PIGA mutation leads to impaired GPI, anchor synthesis for decay accelerating factor, DAFCD55, and membrane inhibitor of reactive lysis, that is MIRL, and also CD59, which protect RBC from complement. There is the mutation in the factors that protects RBC from complement, that is leading to hemolysis. That is also intravascular hemolysis. The triad of PNH or paroxysmal nocturnal hemoglobinuria is that there is Coombs test negative hemolytic anemia, mainly intravascular, and then there is pancytopenia, and then there is venous thrombosis. This is a triad right here. Coombs negative hemolytic anemia, then pancytopenia, then venous thrombosis. That is a triad of paroxysmal nocturnal hemoglobinuria. There is pink or red urine in the morning associated with aplastic anemia, acute leukemias. Lab shows CD55-59 negative, RBCs, negative RBCs, and flow cytometry. In flow cytometry, there is CD55-59 negative RBCs, and also in treatment, we have to do eculizumab, targets terminal complement protein C5. So eculizumab is used. In G6 deficiency case, it is a case of X-linked recessive and G6 PD defect. There is decrease in NADPS, which will lead to decrease in glutathione. So it leads to the increase in RBC susceptibility to oxidative stress, like sulfatrox, antimalarials, and fava beans. These fava beans you have to remember right here. Fava beans. These fava beans, the intake of fava beans in a person with G6PD deficiency will lead to extensive anemia within a few time. It causes extravascular and intravascular hemolysis both. What actually happens is G6PD is a pathway for HMP SONT pathway, right? G6PD is an enzyme for HMP SONT pathway of glucose metabolism. But since it is defective, there is decrease in NADPS formation. This is a function of NADPS to convert glutathione to reduced glutathione. And the function of reduced glutathione is to maintain the RBC integrity. But since there is no decreased reduced glutathione, RBC integrity is not maintained. That increases the RBC susceptibility to oxidative stress, as in sulfatrox or antimalarials or fava beans, and thus hemolysis occurs. This is the pathogenesis right here. The symptoms or findings are back pain, hemoglobinuria, a few days after oxidant stress, and the lab's findings show increased G6PD activity may be falsely normal during acute hemolysis. Blood smear shows RBCs with hinge bodies and bite cells. We talked about it earlier. Bite cells are digmatocytes, right? Digmyocytes, and also stress makes me eat bites of fava beans with hinge ketchup. Okay, mnemonic side here. Stress. So oxidant stress. After oxidant stress, there is hemoglobinuria, right? So oxidant stress makes me eat bites because there are bite cells. Fava beans are very much common associated with G6PD deficiency related anemia with hinge ketchup. That is, RBCs are shown with hinge bodies and bite cells. There is another deficiency right here, pyruvate kinase deficiency. It is autosomal recessive pyruvate kinase defect that leads to the decrease in ATP, so rigid RBCs, so extravascular hemolysis occurs. That leads to the increased level of 2,3 ppc, lead to the decreased hemoglobin affinity for oxygen. The hemolytic anemia in a newborn is usually pyruvate kinase deficiency. Lab shows blood smears, shows Bor cells, as we talked about it earlier. Bor cells, BOR, Bor cells, right? In sickle cell anemia, there is a point mutation in beta globin gene. There is the synthesis mutation in beta globin chain, right? In thalassemia, but there is a point mutation in beta globin gene right here. Single amino acid substitution, that is glutamic acid, will substitute valine. This you have to remember. Glutamic acid will substitute valine in sickle cell anemia, and that leads to the alteration of hydrophobic region on beta globin chain. That leads to aggregation of hemoglobin. The causes are and that causes extravascular and intravascular hemolysis. Pathogenesis is decreased O2, increased altitude, or acidosis precipitates sickling, that is deoxygenated SBS polymerizes with vaso-occlusive disease, like this. These cells, normally these RBCs pass to the small vasculature, right? But these RBCs, these sickleated RBCs, will form a lump in the small vessels, and that will cause ischemia and vaso-occlusive disease. The newborns are initially asymptomatic because of increased fetal hemoglobin and decreased sickled hemoglobin, and heterozygotes, that is sickle cell trait, have resistance to malaria. Okay, this is very much important. If a person who has malaria comes with symptoms of anemia, you should not suspect that he has sickle cell anemia. So sickle cells are crescent-shaped RBCs, as you looked at it, and crew cut on skull X-ray due to marrow expansion from increased erythropoiesis are seen. Crew cut. They are also seen in thalassemia cases. So sickle cell anemia and thalassemia share same feature in skull during X-ray. The complications of sickle cell anemia is aplastic crisis, transient arrest of erythropoiesis due to parvovirus B19, and also autosplenectomy, that is Hall's bodies, are seen, and then that leads to the increase of infection by encapsulated organisms like Salmonella osteomyelitis. Then splenic infarct or sequestration crisis can occur. There are three crises actually: sequestration crisis, aplastic crisis, and vaso-occlusive crisis. This is a triad you have to remember: aplastic crisis, sequestration crisis, then vaso-occlusive crisis. Painful vaso-occlusive crisis occurs. Dactylitis, painful swelling of hands or feet. Then priapism occurs. Then also acute chest syndrome, respiratory distress, new pulmonary infiltration, chest X-ray, common cause of death, and avascular necrosis or stroke can occur. Sickling in renal medulla, that is decreased partial pressure of oxygen, leads to renal papillary necrosis, leads to hematuria, also seen in sickle cell trait. Hemoglobin electrophoresis shows decreased hemoglobin A, increased hemoglobin, fetal hemoglobin, and also increased sickled hemoglobin. The treatment is hydroxyurea that will lead to increased fetal hemoglobin. Since fetal hemoglobin has a higher oxygen binding capacity, that is why we use this. HBC disease is that glutamic acid to lysine mutation occurs. Lysine C, HBC disease, lysine C. So glutamic acid to lysine mutation occurs in beta globin. It causes extravascular hemolysis. HbSC, one of each mutant gene, is milder than HbSS. Blood smear in homozygotes, so hemoglobin crystals inside RBCs are target cells. Okay. So let's talk about our last topic for today, which is extrinsic hemolytic anemias. Last topic for today. So yes, I'm so excited. So the topic, the types of extrinsic hemolytic anemias is autoimmune hemolytic anemia, drug-induced hemolytic anemia, and also microangiopathic hemolytic anemia, and macroangiopathic hemolytic anemia due to infection. This. So in autoimmune hemolytic anemia, what actually occurs? Let's see what actually occurs. A normocytic anemia that is usually idiopathic and Coombs positive. There are two types, that is warm autoimmune hemolytic anemia. This is very high yield. You have to remember all of this. Autoimmune hemolytic anemia is very important because it has a repeated number of questions asked in USMLE Step 1. And cold autoimmune hemolytic anemia. There are two types of hemolytic anemia. In warm type, there is chronic anemia, in which primarily IgG causes extravascular greater than intravascular hemolysis. But this is acute anemia. The cold AIHA is acute. Warm AIHA is chronic, in which primarily IgM plus complement causes RBC agglutination, and extravascular hemolysis is greater than intravascular hemolysis upon exposure to cold. So it leads to painful blue fingers and toes. It is seen in CLL, chronic lymphoid leukemia, and mycoplasma pneumonia, infections, and infectious mononucleosis. You have to remember like that. So that is it. Here in warm AIHA, warm weather is good, right? Okay, so it is IgG in warm AIHA, G for good, and in IgM in cold AIHA there is mnemonics with causes like IgM for mycoplasma pneumonia, for infectious mononucleosis, I am for mononucleosis. So these are the causes for cold AIHA. Cold AIHA is a acute anemia case. Okay. In warm AIHA, it is a chronic anemia case. Findings are spherocytosis and agglutinated RBCs. It's in figure A right here. Right here, you can see these are agglutinated RBCs right here. And also, warm AIHA treatment is steroids, rituximab, and also splenectomy if refractory. Cold AIHA is cold evidence and rituximab. So, drug-induced hemolytic anemia most commonly due to antibody-mediated immune destruction of RBCs or oxidant injury via free radical damage may be exacerbated in G6PD deficiency. That is why drug-induced hemolytic anemia occurs. The common causes include antibiotics like penicillins and cephalosporins, antacids, immunotherapy, and chemotherapy. Findings are spherocytes. If there is spherocytes, then it suggests immune hemolysis. If there is bite cells, it suggests oxidative hemolysis, and they can cause both extravascular or intravascular hemolysis. Microangiopathic hemolytic anemia, MAHA. So, RBCs are damaged when passing through obstructed or narrowed vessels. That is what it occurs in microangiopathic hemolytic anemia. The cause is intravascular hemolysis. It is seen in DIC, TTP, HUVS, SLE, HELP syndrome, and also hypertensive emergency. So the HELP syndrome is low platelet elevated liver enzymes, and this is hemolysis. This is HELP syndrome. It is usually seen in pregnant women. And findings include cystocytes, that is helmet cells, are seen in peripheral blood smear due to mechanical destruction. So cysto means to split. That is what it occurs. And another one is macroangiopathic hemolytic anemia. That is prosthetic heart bulbs or aortic stenosis may also cause hemolytic anemia secondary to a mechanical destruction of RBCs. Cystocytes are seen in peripheral blood smear. There is no difference in peripheral blood smear for microangiopathic hemolytic anemia and macroangiopathic hemolytic anemia. The hemolytic anemia due to infection leads to increased destruction of RBCs, example in malaria and babesia. Okay, that is how we complete our today's session, and we will talk about from leukopenias and all other 10 to 11 pages in our next topics for hematology and oncology. We'll try to cover it up tomorrow. So stay tuned and subscribe if you are subscribe please if you are still here, and motivate me to continue this series, because this will help both of us. We will get motivated, right? So thank you if you are still here. Thank you so much for staying with me and becoming a friend, a motivated partner of study with me. Let's crack this up. We'll get to 60 plus. Thank you.